going to have a wet lab here shortly with Zepto, and I encourage you all to think about it. One thing I can promise you in the next several years, this will change practice styles throughout the world. So it's a device that will maybe make less sense at first, but as you learn more about it, it will make more and more sense. That's been my process with it too. I got involved with it with the, we have the slides. With the offshore research, I did their OUS studies in Central America in 2016. And I was the medical monitor for the FDA trial in late 2016. And the more I've gotten to learn about it, the more I'm convinced it's going to make a difference for all of us. Here's what it looks like. You get a disposable. It's the handpiece. It's about the same size as a vitrectomy device. You have a box that is the control console for vacuum, for electricity, those kind of aspects of it. Here's what it looks like. The nitinol ring is right here. Nitinol is a shape-deforming metal, so you have to linearize this circular device to get it through your opening. 2.2 millimeter works fine. And then that nitinol ring is connected to the power supply by these silver wires. And we'll show how that works here shortly. So for starters, we recently taught Ike Ahmed how to use this device, and he was kind enough to put on his YouTube channel a couple of videos that he customized. So rather than tell you in my words, we'll show you what Ike thought. We have sound, please.
Prior to insertion, we're going to slide the slider all the way forward, pushing the push rod in a forward position, allowing the nitinol ring and silicone skirt to be collapsed. Examining to ensure we have proper configuration without any debris. And now we'll place the device through the 2.2 millimeter incision into the anterior chamber. Once we have it in the anterior chamber, we can then retract the push rod, as you see, partially, just to the end of that silicone skirt. As you see, there's present still in the shaft, moving things left and right. We have good mobility. We're now going to center the silicone skirt, the circular silicone skirt, which is transparent, on the first Purkinje image, lift up slightly on our hand to get good application of the silicone skirt on the anterior capsule. At this point now, we will ask the suction to be turned on, and our system will press the suction button. This allows the suction to be applied, and we will see bubbles, micro bubbles start to be pushed and sucked back into the shaft. As soon as we see this, we pull the slider all the way back, so we have now our push rod all the way back. We now hear suction max, and at this point in time, we can ask the energy to be applied. Within 4 milliseconds, the cut is made. There's energy applied. And within 2 seconds later, we will ask our assistant to release the suction, and now we have created a nice circular capsulotomy, 5.2 millimeter.
So that was Ike's second case. So much for the learning curve. But we had him verbalize all the things we said. Here's the important points, that as you're doing it, you need to think about that. And he's basically repeating it back to himself as he does it.
This is the Zepto precision pulse capsulotomy.
Now, our busiest user in the world for Zepto was Vance Thompson. Vance Thompson did his first case in El Salvador, and I was assistant. So we're going to show you Vance's very first case. He's now done over 1,000. He's doing the steps that Ike verbalized, but we don't have sound for this one. But I wanted to show you what it looks like with a very experienced surgeon doing it the very first time. 2.2 millimeter incision, goes in well, centers well, gets the a good vacuum. When we have very specific processes for doing that, gets a nice capsulotomy there. And we're going to edit out a bunch of the rest of it, but we will show you the little cap that comes out. We sometimes like to pull that out and put it on the cornea just to kind of admire it. Just to let you know that there's no missing pieces. You'll notice that there's a slight opacity to the edge. And the edge, there's an annealing of the collagen, and it causes an upward turning of the edge, and that's what increases the strength of the capsulotomy. In 2016, we published a couple of papers in the Blue Journal talking about relative strength versus manual and versus Zepto versus Femto, and there was no comparison. We did paired human cadaver studies where right eye of an individual, left eye of an individual, manual, Zepto, Femto, Zepto, and in every case the Zepto was quite a bit stronger, from 2 to 4 times as strong. And here's how it does it. The red is the nitinol ring, and then you see the lens capsule. The vacuum pushes the silicone suction cup strongly against the capsule. There's a slight deformation there. You trap a little bit of water molecules there. You create the discharge, the electrical discharge. There's a tiny amount of steam generated, and that both anneals the capsule and cuts it 360 degrees. So one of the great things about it is you no longer have to worry about Argentinian flag sign. With Zepto, that's a non-issue. So all of those tight capsules that you've worried about in the past, you don't put dye in because you don't need it. You put the Zepto in, you do the normal thing with the Zepto, you discharge it, you get your 360-degree capsulotomy, and you're on the way home at that point. Here's what some scanning electron micrographs look like with some schematic. So we've got this cut edge, and then you see it's rolled, and that's what gives you the functional edge, which we believe is why it gives you so much strength, because you don't have those little micro tears in it that you have in all the other methods. Here's what the paired cadaver eye study looked like, giving you a relative strength of one system versus the other. There was no comparison. Here's some of those references that I talked about. We looked at it a couple of different ways, had some different authors contribute to the process, and all that, of course, is available. The OUS trials were published in 2017 in JCRS. I was the lead author on that one. And it talks about how we had a number of exceptionally difficult cases that the Zepto made it much easier. What's very useful for that paper, there are 4 videos tied to it of the cases. So we had 38 cases, as I recall. 4 of the videos were particularly interesting, so we got the journal to host those videos in association with the paper. So you can call up the paper and you can actually look at the videos yourself. The device was CE marked in November of 2015. It was cleared with the FDA in June of 2017. What's interesting, it was cleared exceptionally fast. From submission to approval was 89 days. Indicating to us that it was a pretty clean study, as well as a large effectiveness. We had multiple meetings with the FDA and the FDA leadership, and they were enthusiastic about getting the technology available in the marketplace. Just as important, we've been pursuing as a parallel track a regulatory process that gives us a CPT code. And so we were awarded a CPT code, a Category 3 CPT code, which is a temporary code to use for tracking devices that will become effective January 1 of next year. And there'll be some additional information related to this, but it'll be an important aspect of the device for next year. These are some of the details about the trial. Essentially, we did a very fast trial. Quick enrollment, very clean data, met our endpoints, nearly perfect capsulotomy by all the 8 surgeons almost every time. We had a couple of issues. unfortunately, when you do these kind of trials, you tend to choose very good surgeons. And very good surgeons has their own ideas about how they should follow the rules. And in fact, they like to make their own rules. So in the FDA trials, you're supposed to follow the rules. So we had some surgeons that were less capable of following the rules, although they were very good surgeons. So we got away with it, but that's what led to a couple of our 2 out of the 10. This shows you a case I did in El Salvador, and it's a good one to look at because it illustrates a couple of points we've been talking about. So we've got a tense white cataract. In 3D, you can actually see doming up of the cornea. This would be a classic one we'd all be concerned about. Oh, and by the way, we have a small pupil. So what you can do with this device is you can put the skirt underneath the pupil, so you don't have to do a Mayugan ring, you don't have to use dye, so right away you've saved a lot of time and a lot of money. Now you'll see the vacuum pulling the bubbles out of the eye, and you're going to see the white capsule cortex transferred to the lumina instantaneously. Capsule cut, Argentinian flag sign averted, and out comes the device. And it's that straightforward. And unfortunately, what you see is a brown cataract underneath. But we have an intact, fully secure capsule. And you can do it with hooks if you like. You can put dye in if you like, but you don't have to worry about the Argentinian flag sign. This is another interesting video to think about. This shows you a manual capsulotomy on your left, stage left, versus the Zepto on stage right in a Miyake view. And it gives you an idea, approximate time and approximate zonular stresses. So we've got an experienced surgeon doing it both ways. Zepto's done. We're just getting started on the manual. And you can see, although it's gentle, there's not no traction on the zonules, there's just less. And then you get to the question, which capsulotomy would you prefer? It's pretty self-explanatory. So the other thing that we do is we've got a method for centering this capsulotomy on the visual axis as a way to preserve visual axis information to the end of the surgery. And that's actually what we got the Category 3 code. It wasn't for creating a capsulotomy. That's part of the cataract code. But what we've never had before is the ability to create a method of preserving visual axis information. We approximate it because we sort of kind of tear it. We sort of kind of do it with a femto laser, but don't really. What we can do with the Zepto, because the patient can actually see through it, there's a way that the patient can fixate on the lights and interact with the surgeon and know exactly where they're looking, and then you can center your Zepto over that. And then you can preserve that information to the end of the surgery. Now, there's a question exactly what you can do with it from there, but at a minimum, you have that information when you put the IOL in. And we believe we're going to develop good information that shows that it helps with 360 overlap of the IOL and better centration of the optical axis. But here's how that happens. The surgeon picks one eye that they are fixating with, and you close the other eye or do something so that you're not using that. Then you have the patient look down that coaxial piece, which is basically the light for that eye, and then on modern microscopes, there's a light in each coaxial. To confirm that with the surgeon, and then once we've got that, you're going to cut your Zepto capsulotomy centered on that axis. And then you go through the cataract surgery, and at the end of the cataract surgery, you have that preserved visual axis represented by your capsulotomy so that you can have a little bit better information to center the IOL. The other thing that's happening is we did not intend this, but we were good researchers. We went back and looked at our patients multiple times, and we discovered purely anecdotally that we were getting less PCO when we used the Zepto. And then we decided to study that more carefully. Of course, we all know that PCO diagnosis happens at a large percentage of post-cataract patients. By CMS billing data, it happens approximately 45% of every cataract surgery we diagnose PCO. Approximately 25% of those people get YAG capsulotomies. And I'm not stating that as a matter of legend. We've actually gone to the CMS billing data, and we pulled the data, so we can tell you very precisely this information now, because we want to have this as part of going forward. What exactly is Zepto going to do for us? And that's why I can say with confidence it's going to change our behavior. So here's what the true graph of PCO and YAG looks like from 2011. You can actually track each of those patients that had cataract surgery in 2011. You can track their charges and diagnoses forward. And you can see over time how much of what happens. So we, after we had a little anecdotal look at our patients in El Salvador, we then went and wrote a protocol and we looked at all of them. So these were patients that had very difficult cataracts. You saw one of them. In that world, you tend to get 80 to 90% PCO, as you all well know. So what we found was that our post-ops that had Zepto at between 12 and 16 months had a PCO rate of about 10%. The patients that had a manual had a PCO rate of 80 to 90%. So it was that much of a difference. In addition, what you see up here, can we turn the lights out to get a little bit better contrast? What you'll see is it's not just PCO. We believe that this is going to change the biology of cataract surgery healing. When you look at it, of course there's no PCO, but when you look outside where the anterior and posterior capsule touch, you would expect a lot of fibrosis in patients in Central America. You virtually are guaranteed that. Yet we see it in none of them. This was actually the patient that was the most difficult. This patient had 6 clock hours of zonular loss, and I basically said we shouldn't do this patient here for a variety of reasons. And the patient convinced us that we were either going to do the surgery or they were going to go home and never come back. So we went ahead and tried. It was a long, arduous case. I ended up having to suture a single-piece PMMA, a single-piece acrylic lens through the capsular bag after about 45 minutes of phaco with hooks. And what you can see is, yes, it's not perfect, but that is a surprisingly clean capsule for all of that. And that's what we saw, that we saw all of this clean capsules where we weren't expecting it. And you can see here the nice preserved upturned edge. These edges were not changed over 12 to 16 months. And a magnified view here, just emphasizing that interesting upturned edge, no PCO, no fibrosis to speak of, and a very secure, stable capsule. So that's really was our hope when Femto started. That was kind of what the ideal that we wanted. It didn't turn out that way. But I think that we have a reasonable hope of achieving that with Zepto. Lights back on. So I encourage everybody that doesn't have a prior commitment to come to the Zepto wet lab, and we'll teach you how to do it.